Good morning, ladies and gentlemen. The topic of today's lecture is cutaneous mucinosis. There was a little demand of this topic, and I considered it important to follow this topic with inherited metabolic disorders. Mucinosis is a condition in which mucin accumulates diffusely or focally in the dermis. As the name signifies, mucinosis means deposition of mucin, either diffusely or focally within the dermis. Hyaluronic acid, which is a form of mucin, absorbs enormous amount of water, which explains the excessive induration in this group of diseases. So since the mucin is hygroscopic, so it absorbs a lot of water, as the result of which the skin that contains mucin will become indurated and firm in appearance. Mucin are jelly-like glycosamine glycans, which probably play a part in extravascular exchange of metabolites. It is normally produced in small quantities by fibroblasts. Acid glycosaminoglycans such as hyaluronic acid and heparin stain with toluidine blue, colloidal iron, or with Lichen blue. Furthermore, mucin is periodic acid shift or PAS negative. So the main stains for mucin are toluidine blue, colloidal iron, and Lichen blue, among which Lichen blue is the most commonly used stain. And furthermore, mucin is PAS negative. The cutaneous mucinoses are divided into two main groups: primary or idiopathic cutaneous mucinosis, in which mucin deposits occur and is the main histological feature, resulting in clinically distinctive lesions. While secondary mucinosis is that group of mucinosis in which histological mucin deposition is only an additional feature and a secondary phenomena, in addition to the various other histological features of those diseases. Classification of primary mucinosis. So the primary mucinosis is further subclassified in diffuse, focal, and follicular mucinosis. Among the diffuse primary mucinosis, the most important is the Scleromyxoedema, then Scleredema, generalized myxoedema, Pretibial myxoedema, and Reticulate erythematous mucinosis. Focal primary mucinosis comprises of Lichen myxoedema, acral persistent papular mucinosis, cutaneous focal mucinosis, and myxoid cysts. While the follicular primary mucinosis include pincus follicular mucinosis and Urticaria-like follicular mucinosis. So our lectures is mainly focused on primary cutaneous mucinosis. I would like to discuss here the secondary mucinosis, in which mucin deposition in the dermis is a secondary event in addition to other histological features. This group includes a large number of diseases, but we are not going to discuss these diseases in today's lecture. The lecture of these diseases have been given in various other sections previously. So the epidermal causes of secondary mucinosis include mycosis fungoides and basal cell carcinoma. While the dermal causes of secondary mucinosis include granuloma annulare, connective tissue diseases like lupus erythematosus and dermatomyositis, Dego's disease, nephrogenic systemic fibrosis, chronic graft versus host disease, and basal cell carcinoma again, dermatofibrosarcoma protuberans, and neurofibroma. Causes of secondary follicular mucinosis are the hematological malignancies like mycosis fungoides or follicular mucinosis associated with mycosis fungoides, lupus erythematosus, cutaneous drug reactions like imatinib and captopril, and insect bites. The systemic manifestations which are associated with mucinosis or primary mucinosis are the monoclonal gammopathies which are seen in Scleromyxoedema and Scleredema, diabetes or infection seen in Scleredema, hyperthyroidism seen in pretibial myxoedema, hypothyroidism in generalized myxoedema, and lupus erythematosus, dermatomyositis, scleroderma in papular and nodular mucinosis, all seen in connective tissue diseases. So first, the dermal mucinosis. Our focus is the primary mucinosis. Lichen myxoedematosus, also called as papular mucinosis. Lichen myxoedematosus is a cutaneous myxoedematous condition that is characterized by formation of lichenoid papules, nodules, or plaques due to abnormal dermal mucin deposition. In addition, there is proliferation of fibroblasts with fibrosis and excessive deposition of glycosaminoglycans in the skin in absence of thyroid diseases. There are two main divisions of lichen myxoedematosus. First is a generalized papular and sclerodermoid form that is called as Scleromyxoedema of ardent gotron, while systemic or even lethal manifestations. Then there is a localized papular form which does not have any systemic implications and run a benign course. Scleromyxoedema. It is a sclerotic variant of lichen myxoedematosus characterized by generalized papular eruption on a sclerodermoid background, mucin deposition, increased fibroblastic proliferation, fibrosis, and monoclonal gammopathy. So it is characterized by excessive mucin deposition along with fibroblastic proliferation, and the fibroblastic proliferation is the cause of induration, while mucinous deposition is cause of the papular eruption. Mean age of onset is 59 years. Pathogenesis. Cytokines and monoclonal gammopathies, tumor necrotic factor alpha and beta, and interleukin 1, 6, and tumor transforming growth factor beta, and or polyclonal or monoclonal immunoglobulins may induce upregulation of glycosaminoglycan synthesis from the fibroblasts. So fibroblasts secrete increased amount of glycosaminoglycans in response to various mitogens, which include these chemokines, cytokines, and polyclonal or monoclonal immunoglobulins. Autoimmune syndromes induced by adjuvants. There are case reports of scleromyxoedema following intradermal hyaluronic gel injection or after breast silicone implantation. Triad of histopathological finding. These triad include diffuse deposition of mucin composed mainly of hyaluronic acid in upper and mid reticular dermis. This bluish area, which is seen between the collagen bundles, is the mucin. So the first histological finding is the increased amount of mucin. Then in addition, there is increase in collagen deposition. And thirdly is the proliferation of irregularly arranged fibroblasts. So the three main features are the mucin deposition between the collagen bundles, increased number of collagen fibers, and increase in amount of fibroblasts. The collagen fibers are widely separated by mucin deposition. You can see this mucin deposition that is separating the pinkish collagen fibers, and fibroblasts are increased in number. You can see the large nuclear size of these fibroblasts. Elgin blue is the stain which we use to highlight this mucin deposition. Clinical features. The typical skin features are widespread eruption of 2 to 3 millimeter, firm waxy, closely spaced, dome-shaped papules involving the dorsal aspects of upper limb, head and neck, and upper trunk. The papules are often arranged in linear pattern, and the surrounding skin is shiny and thick, that is sclerodermoid. Glabella is involved with deep longitudinal folding that gives the leonine facies. Eyebrow, axillary, and pubic hairs may be sparse. Deep furrowing is also evident on the trunk, shoulder, and limbs, which is the Shar Pi sign. You can see the typical leonine facies on one side and small diffuse papular eruption, which is typical of Scleromyxoedema. So the severely affected patients show sclerosis and linear papules on the hands. The longitudinal, deep longitudinal folding on the face is obvious, and this is giving the leonine appearance. Erythematous and infiltrated. Plaques develop with stiff skin, sclerodactyly, and reduced mobility of mouth and joints of hands, arms, and legs. Over the proximal interphalangeal joint, a central depression surrounded by an elevated rim due to skin thickening is often referred to as the donut sign. You can see this donut sign here. This is fold of skin which is raised and thickened. Mucosal lesions, telangiectasias, and calcinosis is absent. So these features will differentiate Scleromyxoedema from Scleredema. Hands may simulate sclerodactyly of Scleroderma, but the clinical appearance of numerous small papules on erythematous and thickened background and donut sign on the proximal interphalangeal joint will help differentiating the sclerodactyly seen in Scleromyxoedema in comparison with sclerodactyly that is seen in Scleroderma. Differential diagnosis. The first is the Scleroderma or systemic sclerosis. In systemic sclerosis, there are absence of papules, anti-nuclear antibodies are positive, and anti-centromere or anti-SCL70 is positive in most of the cases. Scleredema. In scleredema, there is symmetrical non-pitting induration of neck and upper trunk without having papules. There is antecedent upper respiratory tract infection or association with diabetes. Then nephrogenic systemic fibrosis is a secondary mucinosis due to renal dysfunction and exposure to gadolinium. Lack of facial involvement and monoclonal gammopathies are both against the diagnosis of Scleromyxoedema. Investigations. In addition to the skin biopsy, Serum electrophoresis with immunofixation is mandatory. And IgG class paraproteinemia is almost always found on serum electrophoresis. Thyroid functions are normal. Bone marrow studies show mild plasmacytic infiltration, and high resolution cutaneous ultrasonography may become useful diagnostic tool as well as monitoring the disease activity for skin thickening. Prognosis of scleromyxoedema is poor despite of multiplicity of potential treatments. The main cause of death include dermatoneurosyndromes, in which scleromyxoedema is seen with fever, convulsions, and coma. Involvement of CNS, heart, kidney, or progress to overt melanoma worsens the prognosis. The treatment ladder. First line treatment is intravenous immunoglobulin at a dose of 2 grams per kilogram for 5 days for at least 6 months. 5 days a month for at least 6 months. Second line treatment includes thalidomide, 100 to 400 milligram per day, systemic steroids, both commonly in combination with intravenous immunoglobulin rather than as a monotherapy. So the first line and second line therapies are usually combined. Then third line therapy include autologous peripheral blood stem cell transplantation or bortezomib and dexamethasone. Additional therapies include oral retinoids, cyclosporin, interferon alpha, hydroxychloroquine, chemotherapeutic agents like melphalan, like 2-chlorodeoxyadenosine, cyclophosphamide, or methotrexate. Physical therapies include plasmapheresis, PUVA or UVA1, electron beam therapy, and extracorporeal photochemotherapy. Localized lichen myxoedematosus. So this is the other form of lichen myxoedematosus in which the localized lesions are seen. Patients have a small firm, waxy papules or nodules and plaques confined only to few sites. It's not a generalized disease. And there are no sclerotic feature. There is no paraproteinemia, no systemic involvement, and no association with thyroid diseases. This is further subclassified into 4 subtypes: acral persistent papular mucinosis, discrete papular lichen myxoedematosus, cutaneous papular mucinosis of infancy, and nodular lichen myxoedematosus. Histopathology is generally of a grand zone, that is a normal zone between a normal epidermis and abnormal dermis, with increase in mucin that is seen in upper reticular dermis. The fibroblastic proliferation is variable, but fibrosis is not marked and may be absent. The first subtype is acral persistent papular mucinosis. The name describes the clinical feature. There are multiple ivory to skin colored papules exclusively on dorsal aspects of hand or extensor surfaces of distal fora. Then discrete papular lichen myxoedematosus. In this, reddish, violaceous or skin colored papules, 2 to 5 mm in size, numbering from just a few to hundreds, are seen on trunk and limbs in a symmetrical fashion. Then the third is nodular lichen myxoedematosus. This is characterized by multiple nodules on limb and trunk with mild or absent papular component. You can see the nodules here in the pictures. And last subtype is Papular mucinosis of infancy. It's a rare condition and characterized by opalescent papules on upper arm, neck and trunk noted at birth or develop a few months later. Some cases appear to progress. Certain cases of cutaneous mucinosis in infancy are in fact the infantile presentation of Lichen myxoedematosus. Association of Lichen myxoedematosus, localized type is HIV infection, hepatitis C infection, or exposure to toxic oils or L-tryptophan. Prognosis. The disease runs a chronic but benign course in absence of systemic involvement. Progression to Scleromyxoedema have never been proved. Management. Localized Lichen myxoedematosus is a benign condition that often does not require any therapy. That is wait and see approach. If we want treatment, then many treatments are tried that include dermabrasion, carbon dioxide laser, electrocoagulation, topical or intralesional corticosteroids, or higher hyaluronidase injections, oral retinoids, Sorelin ultraviolet A or PUVA with variable result. Topical calcineurin inhibitor may be of some benefit. Spontaneous resolution occur even in the setting of HIV. The next kind of diffuse mucinosis is reticulate erythematous mucinosis. This is characterized by persistent reticular macular erythema or erythematous papules and plaques in midline of back or chest with mucinous and round cell infiltrate in the dermis and is frequently called as REM syndrome or reticulate erythematous mucinosis syndrome. Etiology. The REM has been considered as a photoaggravated disorder, but the role of sunlight is actually controversial. Oral contraceptives, pregnancy, menses, heat, X-ray therapy, and perspiration have been implicated to promote or exacerbation. Familial cases suggest a genetic predisposition. Associated disorders include malignancies, that is hematological malignancies, breast, lung, and colon, thyroid dysfunctions, SLE, diabetes, idiopathic thrombocytic purpura, thrombocytopenic purpura, and viral infections, especially HIV. The histopathology shows a perifollicular and perivascular infiltrate of mononuclear cells in upper and mid dermis. So the infiltrate is quite significant. In addition to the infiltrate, increase in dermal mucin, hyaluronic acid is seen in the dermis with separation of collagen fibers. The collagen fibers are otherwise normal. Clinical features. Most patients are young or middle-aged female, but condition has been reported in children. There are areas of pink, reticulate or sheet-like erythema present on the central part of the chest and back. The area becomes infiltrated and then slowly increase in size. The reticulate persistent macular or infiltrated plaques are associated with burning or itching. The treatment ladder. First line treatment is the anti-malarials, hydroxychloroquine 400 mg daily. Or second line include topical and systemic corticosteroids, topical calcineurin inhibitor, and third line include phototherapy, UVB or UVA, and pulse dye laser. Third disease to be discussed today in diffuse cutaneous mucinosis is Scleredema, also known as Scleredema of buschke. It's a rare disorder of unknown cause in which symmetrical diffuse, progressive non-pitting, swelling and induration, of upper part of body is seen frequently after infection, but also in diabetes. So the eruption is generally symmetrical, diffuse, non-pitting swelling and induration, mainly seen on the upper part of the body that include the upper back, upper chest, and the upper limbs. It is caused by thickening of the dermis due to deposition of mucin. There is no papular eruption on top of the thickened or indurated skin. It spontaneously clear in months or years. The older term, Scleredema adultorum, is incorrect as the condition can occur in childhood. 29% of cases start before the age of 10 years and further 22% between ages of 10 and 20 years. Type of Scleredema adultorum. The first is diabetic and second is the non-diabetic. So among the diabetic, 20 to 50% are included. It is a slowly progressive disease with non-resolving course and occur in patients with poorly controlled diabetes and insulin-dependent diabetes, while the diabetic control improves the outcome. The non-diabetic scleredema include 25% idiopathic, 25 to 50% with preceding febrile illness, mainly post-streptococcal, with complete resolution in months up to 2 years. 10 to 20% are associated with monoclonal gammopathies, including multiple myelomas with slowly progressive non-resolving course. Anecdotal evidence shows association with HIV, internal malignancy, and autoimmune disorders. Pathogenesis is unknown. An increase in type 1 collagen synthesis by dysfunctional fibroblasts have been demonstrated. In diabetic scleredema, accumulation of collagen may be due to irreversible non-enzymatic glycosylation of collagen and resistant to degradation by collagenase. Alternatively, excessive stimulation of insulin, microvascular damage, and hypoxia may induce abnormal synthesis of collagen and mucin. Streptococcal hypersensitivity, injury to lymphatics, and paraproteinemia may all play a role. Histopathology shows thickened dermis, often at the expense of subcutaneous fat, and acrine glands are seen situated in the mid-dermis. These are the acrine glands. They should be present at the lower 1/3 of the dermis. Collagen fibers appear swollen, and abundant mucin is seen, which is highlighted by Alchian blue stain. Clinical features. It's an uncommon disorder, more common in female patients without diabetes and male with diabetes. Although condition may apparently start spontaneously, there is a history of infectious episode for a few days to 6 weeks prior to the onset in 65 to 90% of the cases. This episode can be an influenza, tonsillitis, pharyngitis, measles, mumps, scarlet fever, impetigo, or cellulitis. Prior streptococcal infection appear to be particularly common. Sometimes there is a history of trauma. The prodromal symptoms of slight fever, malaise, muscle and joint pains occasionally occur between the infectious episodes and onset of induration. Onset is more insidious in diabetes. The disease is further characterized by firm non-pitting edema and induration that typically begins on the posterior neck, spreading to the upper back, shoulder, and scalp. Erythema and putty orange appearance of skin are commonly observed. there is no sharp demarcation between the abnormal and normal skin. Hand and feet are characteristically absent or spared. Patients often complain of movement restriction comprising limited body mobility and facial expression, or difficulties in mastication and articulation. Tongue and pharynx may be involved with difficulty in swallowing. There is marked thickening and non-pitting induration of skin of upper back. Skin is bound down due to involvement of papillary dermis. Complications: stiffness and restriction of movement of joints, pleural and pericardial effusion, skeleton and cardiac muscles may be affected, ocular manifestations and parotid gland involvement. Prognosis is largely dependent on the underlying etiology. Post-infectious scleredema run a benign course, self-limiting, and resolve spontaneously between 6 months to 2 years. The scleredema associated with diabetes or monoclonal gammopathy run a chronic and disabling course with little tendency to remission. Early death may occur when an internal organ is involved. Laboratory investigations. Recent infection should be excluded with throat swab, culture, and anti-streptolysin and titers. Fasting blood glucose or glycosylated hemoglobin measurement, then serum protein electrophoresis and immunofixation. Paraproteins of scleredema are mostly IgG kappa. ESR may be moderately elevated. Ultrasonography and MRI to evaluate skin thickness at baseline and after treatment. Differential diagnosis include systemic sclerosis, but there is sclerodactyly, Raynaud's phenomena, mid-fold capillary changes, and serum autoantibodies in systemic sclerosis. Additional DDs include myxoedema, lymphedema, cellulitis, dermatomyositis, and edema of cardiac or renal origin. Treatment: there is no effective remedy. However, the first-line treatment include treatment of primary disease like diabetes or multiple myeloma, along with phototherapy with UVA, UVA or narrowband UVB. Second-line treatment include intravenous immunoglobulins, immunosuppressive agents like cyclosporin A and methotrexate, high-dose penicillin, corticosteroids both local and intralesional, and tamoxifen and allopurinol. Third-line treatment include electron beam therapy and photopheresis. Now we are going to discuss the second heading or second topic of today's discussion, that is the focal mucinosis. Among the focal mucinosis, we are going to discuss few conditions separately. So the first condition is the pretibial myxoedema. There is a localized edematous and thickened pretibial plaque, 1 to 5% of patients with Graves' disease, but in 25% of patients who have X ophthalmos. So it is seen in 1 to 5% of patients of the Graves' disease, but it is more seen, that is more than 25% in patients who have X ophthalmos. The peak age of incidence is 50 to 60 years. The same process often occurs on the dorsum of hallux and many other sites like lower abdomen, arm and buttocks and neck. Etiology: the TSH receptor antibodies may stimulate the production of mucin from the fibroblasts. Some cytokines like tumor necrotic factor alpha and interferon gamma also induce glycosaminoglycan synthesis from fibroblasts. And the fibroblasts from the dermis of lower extremity have been found to be more sensitive to this factor. Insulin-like growth factor 1 receptor antibodies, trauma, tobacco, or lymphatic obstructions may also play a role. Histopathology shows separation of collagen bundles by large quantities of mucin and loss of collagen fibers, a perivascular lymphocytic infiltrate with normal or increased number of fibroblasts. So in this condition, mucin is deposition heavily, but there is no fibroblastic proliferation. There is increased number of fibroblasts, but there is no increase in collagen deposition. Mucin is, as shown before, is Lichen positive, Lichen 2 positive. Clinical features. The lesions first appear on the anterolateral aspect of the lower limb and only later extends to the back of legs and feet. Nodules are pink and skin colored, yellow or waxy with prominent hair follicles, giving a pudgy orange appearance. There are 4 main clinical variants: diffuse non-pitting edema 43%, plaque type 27%, and nodular in 18% and elephantiasis in 5%. There may be hyperhidrosis or hypertrichosis over the lesion. These are the nodular eruption. This is the pudgy orange appearance, and this is the elephantiasis. Association with morbidity is usually not severe, except for patients with elephantiasis who are less likely to have remission. The entrapment of peroneal nerve may cause foot drop. Investigations: thyroid stimulating hormone is abnormally low, and low acting thyroid stimulator antibodies are elevated. Treatment. The initial treatment include minimizing the risk factors such as reducing weight, reducing tobacco use, and normalizing the thyroid functions. First line of pharmacological therapy is medium to high potency topical corticosteroid applied under occlusive dressing or delivered by intralesional injection. For severe elephantiasis form, rituximab, plasmapheresis, or intravenous immunoglobulins, and occasionally octreotide with and without surgical shave removal. The use of compression stocking and gradient pneumatic compression is useful as it improves the lymphedema. Localized myxoedema may clear spontaneously on average after 3.5 years. The second of the focal cutaneous mucinosis, primary type, is a self-healing cutaneous mucinosis. It's a rare disorder of unknown etiology in young people from 13 months to 15 years, characterized by transient cutaneous lesions. Because it is a self-healing, suggested to be secondary to a reactive or repetitive response to chronic antigenic stimulation as occur in chronic viral infections. Histologically, they are papular lesions showing mucin deposition with mild inflammation and a small increase in fibroblasts, while the nodules show deep mucinous areas associated with band of fibrosis. It is characterized by following criteria. There is an acute eruption, multiple papules, linear fashion on face, neck, scalp, abdomen, and thigh. Mucinous nodules on face and periarticular area of the limb. Systemic symptoms include fever, arthralgia, weakness, and muscle tenderness. Absence of paraproteinemia, bone marrow plasmacytosis, and thyroid dysfunctions. A spontaneous resolution in a few weeks to many months. Hence, aggressive therapy should be avoided. Then the third type is cutaneous focal mucinosis. It is a benign localized form of cutaneous dermal mucinosis, occur in adults of either sex but also in children. A reactive lesion in which trauma may act as a trigger. The histology shows diffuse, ill-defined dermal accumulation of mucin, which is sparing the subcutaneous tissue, with normal or slightly increased fibroblasts. Patient as an asymptomatic solitary skin-colored papule or nodule, sometimes with cystic appearance, occur anywhere on the body. Surgical excision is the treatment of choice and relapses are common. You can see this cutaneous focal dermal mucinosis. Then the last is the dermal myxoid cyst. It is a benign ganglion cyst of the digits. Two varieties, the ganglion type derived from the joint fluid and located over the joints, and myxomatous type derived from fibroblast located between the interphalangeal joints. It is translucent, dome-shaped, soft, 3 to 10 mm nodule. There is antecedent trauma which is documented. There is no histopathological lining in histopathology, and excess mucinous deposition results in a fluid-filled cavity or a cyst. Overlying epidermis appear attenuated. Treatment is by excision, by multiple needling or aspiration, followed by steroid injection, sclerosant injection, chemotherapy, infrared coagulation, or carbon dioxide laser. Focal mucinosis. Among the focal mucinosis, the first and foremost is the follicular mucinosis that is characterized by infiltrated plaques with follicular prominence, or you can say the mucin is infiltrated in the follicles with scaling and loss of hairs, histologically by accumulation of acid glycosaminoglycans in sebaceous glands and hair follicles. There is male predominance. Cell-mediated immune system play a role in etiology. Follicular mucinosis may be subclassified into 3 groups. First and the largest group, also called as the pincus follicular mucinosis, consists of solitary or few lesions clearing spontaneously in 2 months to 2 years. Second group are patients whose lesions persist or new lesions continue to develop over many years. And third group is 15% of cases, and the mucinosis is associated with CTCL. Patients with lymphedema associated follicular mucinosis tend to be older, more than 45 years, than those with benign disease, peak between 20 to 40 years. Some regards follicular mucinosis as a non-specific follicular reaction observed in association with lupus erythematosus, angiolymphoid hyperplasia, Hodgkin disease, and cutaneous B-cell lymphoma. Clinical features, 2 presentation. The first is indurated bald plaques over head and neck, single or multiple, and is a feature of benign follicular mucinosis. Grouped follicular papules with more generalized distribution, more likely to have lymphoma-associated disease. Some of the papules may ulcerate, alopecia may also occur, irritation can be troublesome, destruction of follicles give rise to patches of pigmented alopecia, which may be studied with horny plugs. Unfortunately, no single clinical feature distinguishes the lymphoma associated from the benign one. So this is the pincus follicular mucinosis. You can see a patch or a plaque which studied with follicular papules. The papules have rather waxy appearance, and the ear is also involved, which is swollen and disfigured. So generalized group follicular papules are seen on the face as well as on the trunk. There can be a soft boggy swelling with gelatinous consistency. Sometimes mucin can be squeezed out of the affected follicles. Clinical course, the disease regresses in 2 years. Chronic relapsing, initially benign, later developed lymphoma associated with lymphoma carries a poor prognosis. Histopathology. Low power view shows marked mucinous degeneration of the hair follicles and sebaceous glands. These are the mucinous deposition seen among the hair follicle and sebaceous glands, which are totally replaced. High power view of abundant mucin. And there is a mixed infiltrate comprising of lymphocytes, histocytes, and eosinophils. You can see the eosinophils here. The mucin is strongly positive with Lichen blue. The MF-associated variant node heavy lymphocytic infiltrate in the surrounding dermis and even with epidermotropism. The markedly atypical lymphocytes are present, which are CD4 positive. Diagnosis. Eczema, seborrheic dermatitis, traumatic alopecia, and tinea capitis should be closely monitored. Biopsy and serial sectioning of tissue should confirm the diagnosis. Treatment. There is no specific treatment for pincus follicular mucinosis. Wait and see approach is the best, and many cases heal spontaneously in 2 to 24 months. The agent used for treatment with benign and CTCL associated follicular mucinosis include topical intralesional or systemic corticosteroids, topical retinoid, topical bexarotene, topical calcineurin inhibitor, imiquimod, dapsone antimalarial, indomethacin, minocycline, oral isotretinoin, phototherapy, and UVA1 phototherapy, photodynamic therapy. The second type of follicular cutaneous mucinosis, primary type, is the Urticaria-like follicular mucinosis. A follicular mucinosis is present with cyclic eruption of Urticaria-like lesions on the face in middle-aged man. On histopathology, presents with mucin deposition inside the hair follicle, associated with perivascular and perifollicular infiltrate of lymphos and eosinophils. Patient with recurrent pruritic, urticarial papules and plaques of face and neck on a rosiform or seborrheic background, neither follicular plugging nor alopecia is seen. The disease has a good prognosis, although it may last up to 15 years. Antimalarials and dapsone have been reported to be beneficial. Among the secondary mucinoses, we are going to discuss only one disease, that is the papular and nodular mucinosis in connective tissue disorders. The condition is characterized by skin-colored papule, nodule, or plaque on trunk and upper extremities, accompanied or antedated by connective tissue disease, most likely SLE, and rarely dermatomyositis and scleredema. Cutaneous lupus mucinosis occur in 1.5% of patients with lupus erythematosus in 4th and 5th decades of life, with prominence in male adults. Pathophysiology is increased aminoglycans production by dermal fibroblasts stimulated by cytokines and immunoglobulins. Mucin is abundant throughout the dermis and sometimes subcutaneous fat, occasionally associated with slight to moderate perivascular lymphocytic infiltrate. These are the dermal nodular mucinosis. Positive lupus band test seen on DIF. Clinical course may or may not be related to underlying connective tissue disease. Periorbital mucinosis is unusual presentation. Cutaneous mucinosis and dermatomyositis usually follow a myositis episode with erythematous nodules and plaques on the trunk. Association with both type of scleroderma, systemic and cutaneous. Management. Therapy of papular and nodular mucinosis is same as for the connective tissue diseases themselves. Sunscreens, topical or intralesional corticosteroids, and oral antimalarials can be effective in cutaneous lupus mucinosis. Systemic corticosteroids and oral tacrolimus are useful for resistant cases. So this takes us to the end of this talk. and I thank you for a patient listening. Goodbye and have a good day.